Good morning, everyone. Hope that we have been enjoying the discussion. As a part of the planning committee, we definitely have been enjoyed the many calls of planning and pulling this together. So we're excited to see where the conversation goes today, and it's an important one. And that brings us to our second panel, which is attentions and perspectives around BMI. Again, for those who I don't know, my name is Dr. Michael G. Knight. I'm an associate Chief of Quality and Population Health at the George Washington University, where I also serve on the faculty and as a head of healthcare delivery transformation. And by clinical training, I'm an internist and obesity medicine specialist, also practicing at our facility just up the street. I'm going to be moderating this session, and we're going to have our first panelists come up and present. Each panelist is going to present for about 10 minutes, and then we'll have discussion and hopefully take some time for questions from the audience and online. So for this session, we'll be hearing from three excellent speakers. Again, the full bios of all of our speakers are in the packet and on the web page, but it's my pleasure to introduce our first speaker, Dr. Jamy Ard. Dr. Ard is a professor in the Department of Epidemiology and Prevention and the Department of Medicine at Wake Forest University Baptist Medical Center. He is co-director of the Wake Forest Baptist Health Weight Management Center and a member of the Roundtable on Obesity Solutions. Please give a warm welcome to Dr. Ard.
Good morning, and I appreciate the opportunity from the committee to be able to share some thoughts with you today. Let's see if I can get back to Zoom and share screen. And voila. Little Zoom magic. All right. All right. I have 10 minutes and I am energized by the previous conversation, but I'm going to try to stay within my 10 minutes. I have been tasked with providing a clinician perspective, and some of what I say will mirror what Dr. Ryan said, which is always a good thing. So let me just jump right in. I'll show my disclosures here. I work with a number of different groups and have memberships in different societies related to obesity treatment and prevention. So I'm going to talk about three different areas: current usage of BMI in practice, some of which you've already heard, make the case around the utility of BMI, and then talk about some of the challenges in terms of patient interactions that I face. And this won't be a heavy data talk. This is just me talking about what we do in practice. So as Dr. Ryan said, BMI is really a screening tool. And it's difficult, as she said, to estimate fat mass in clinical practice. We certainly don't have a reliable way to do that easily. Dr. Flegel mentioned this report previously, and I'll just point out that committee noted two things that I think are really important: is that the risk associated with BMI should be interpreted in the context of other health indicators. And you've already heard other people say that. So that's really important. And then the second issue is that weight gain within a given BMI category is of concern. So even if someone has a quote unquote normal BMI, if they are gaining weight as an adult, that's typically abnormal. The only people who are gaining weight actively are typically wrestlers or people who are pregnant. No one as an adult typically is intentionally gaining weight. And so that should be another sort of thing that we need to think about: is what is the weight trajectory for an individual versus what is the current sort of static BMI at that point in time. The other issue is that BMI is useful for treatment indication. So a lot of the treatments that we have are indicated based on where the individual's BMI is. And this is standard clinical practice. And you can argue whether these cut points are right or wrong, or whether they absolutely are specific for the type of treatment that is provided. But for example, pharmacotherapy is available for individuals with BMI of 27 and at least one complication related to overweight, or BMI of 30 or greater. Surgical BMI cut points are listed there. There are new recommendations that have actually suggested that those cut points and indications for surgical treatment should be lower. And then you have programs like the Centers for Medicare and Medicaid that essentially provide guidance for what they will cover for behavioral therapy. So if you're a Medicare beneficiary and you want assistance with a behavioral weight loss strategy, you have to have a BMI of 30 or greater. So we see patients all the time who come in with a BMI of 29 and said, I've gained 30 pounds since I retired. I don't have a routine. I feel like my health is going down the tubes. But we can't actually use this treatment program because their BMI is not 30. And to make it, sort of even more interesting, if we treat someone who say, let's start off with a BMI of 31, technically we're not supposed to be able to bill for that care once they get below a BMI of 30. So if we're successful with helping that patient, then we can't continue to treat them. And then you also see things like the U.S. Preventive Services Task Force make recommendations that have, again, integrated within it a BMI indication. Now, the other, sort of strategy or use of BMI is not in treatment indication, but what I'm calling allocation. So this is where a payer or employer might say, well, we don't want to be able to cover, we're not interested in covering everyone who has obesity. And so we're going to put some gates around what treatments we will cover. And the employer can decide, yeah, we're going to only cover individuals who have a BMI of 40 and higher. And we'll make surgical treatment available for them, but pharmacotherapy won't be available for anybody else. And maybe we'll do some workplace wellness initiatives to otherwise cover everybody else. And that's totally variable based on who your employer is, who the payer is, and the type of policy that you have. The other area of usage, as Donna had talked about, is in diagnosis. And so BMI is obviously very easy to do. It's standard. You don't have to have a lot of fancy equipment in order to be able to do it. Most places can do it. And as she talked about, it's always in the electronic health record. The challenge is, as we've also talked about, is that you don't really have any further distinction about that. You don't know where the fat is. You don't know what the duration of the excess fat is, subcutaneous versus visceral, the distribution, et cetera. And so that creates a challenge because you could look at two people by age, for example. We know that as we get older, we lose fat, lean mass and gain fat mass. And so an individual can stay the same weight, same BMI, but have a different percent body fat. And so this is, again, a challenge, but it's part of the diagnostic criteria. So every time I see a patient who has Medicare as a payer, we have to put in the actual BMI code in order to get payment for that particular patient, the exact BMI. The other issue is BMI does have some utility in that at this point in time, most providers know what it is. They may not know exactly all of the details that we're discussing today, but most people would say BMI equals body mass index. And I think that those cut points are broadly understood. Now, certainly people misuse those cut points or don't, implement them correctly, but there's definitely an association between body mass index and any number of clinical risk factors, quality of life. There's plenty of data that show that it actually is fairly indicative of excess fat mass. So the correlation between, say, DEXA and BMI is actually fairly good in terms of a relationship of around an R squared of around 0.7 to 0.8, depending on the population. We always make these sort of extreme exceptions and say, well, it doesn't work well in football players or in, the sarcopenic individual who's, 80 years old, but the majority of us are in the middle. And there's a fairly good correlation between body mass index and that excess fat. Now, one of the things that I think is really makes this even more challenging, though, is sort of the interaction as a clinician who I feel like I understand BMI fairly well. I understand that history, I understand the uses and so forth, but our patients often don't have any of that context or understanding. And they have lots of different perspectives that they bring to the table. And because BMI is so integrated into our treatment distribution, allocation, and indications, it's important for us to be able to get that right, because I think that those conversations that we have with patients around BMI, become part of that stigmatizing process. And so some of these conversations can go terribly wrong and create lots of harm. And some of them can be very educating and actually get people engaged and focused on health. So here's some examples of challenges, I think. One is that patients assume that the only way to get healthy is to get to a normal BMI. And that's not true. We know that the risk between BMI and health changes as soon as people start losing weight. As soon as you implement a negative energy balance, you start to see changes metabolically that happen. And the relationship between BMI is then diminished or changed dramatically. So I always tell patients, I could have two patients in front of me with BMI of 35, one that went from 30 to 35, the other that went from 40 to 35. Metabolically, they're going to be very different, even though their number, the BMI number, is the same. So again, this is where the health context comes in. The other thing to remember is we define obesity by BMI, but obesity is not just excess fat. If obesity were just excess fat, the best treatment for it would be liposuction or some type of body sculpting. Remove the fat and be done. The issue of obesity is about energy dysregulation, and BMI is only measuring the long-term result of that energy dysregulation. So it's not the measure of the disease that we actually are trying to treat. The second thing is patients assume that BMI doesn't apply to them. And so you hear conversation around BMI is racist, it doesn't apply to me, it's not for non-whites. And a lot of the time you just sort of, in that case, have to put that aside and let's just talk about your health. Let's not worry about what the chart says and those types of things. If losing weight might be helpful to you, would that make sense? And then the last thing is that trying to explain access to various treatments to patients when there's really not a lot of medical justification based on BMI is often challenging. So if I have a patient who has a BMI of 38 and they don't have any health complications that would qualify them for surgery, but they really are suffering from that excess weight, both mechanically, physically, mentally, and saying to them, well, you can't have surgery because you don't have a BMI of 40, doesn't make sense. That's an incentive to gain weight. And we see that happen. Or the patient has a BMI of 34 and really bad diabetes, but can't get surgical treatment or another type of treatment because they haven't hit that threshold. So we wait for people to gain weight and then say, okay, now that you've gained enough weight, we can apply this therapy. So in summary, I feel like, BMI is definitely integrated into our clinical practice. And I agree with Donna to some extent that the only way we can move away from that is to have something that's simple to do, as simple as BMI and cost effective as BMI, but maybe more reflective of the risk that we're actually dealing with and an indicator of true energy balance. But it's used as a gate, for access to treatment. And I do think that you can use it responsibly when you are actually thinking about the entire patient and the context of that patient. And you can apply it to large, different populations of people. I know that many people just don't understand what it is and what it's not. And that becomes a real challenge in terms of having really well-informed conversations around this with our patients. So thank you for your time. Look forward to further discussion.
Thank you, Dr. Ard.